someone said that person has an acute abdomen, what they probably mean is that person has a surgical abdomen, and they've got peritonitis causing their acute abdomen. The acute abdomen has a load of different reasons, but it's that sudden onset, severe acute pain that someone would get. And there's a large variety of causes, some of which we'll go through today. And because there's such a wide variety of causes, you need a really structured approach to these patients when you go and see someone to make sure that you have an appropriate range of differentials so that you don't miss what's causing it. So I thought we'd do it as a bit of a case study. I'm sure, have all of you run through A&E yet, or going to go through A&E? These are the most common places that you will see someone with an acute abdomen. They tend to come through A&E, either GP referral or a 999 call. You might occasionally pick them up on the medical ward, and you'll see them in the SAU, but this is normally the first place that they are diagnosed. So say you're on nights in A&E, and you're called to see a 65-year-old man with acute abdominal pain. If you've done A&E, you'll know that that's a very common presentation, and that's all you'll get. That'll be your STEM, present and complaint, acute abdominal pain, and you have to go and see them. So you need to be able to distinguish if there is an acute surgical pathology in that patient compared to someone where there isn't, and the reason for that is that you need to decide whether you need to get a surgeon involved, whether that person's going to need an operation or not. First of all, when you go and see that patient, what do you want to know when you go and see them?
More about pain?
Yeah?
History of presenting pain.
Brilliant. Fundamentally, from the end of the bed, what's the first thing that you can spot in a patient? Before you've got any of that information, what will you be able to tell?
Is one well?
Precisely. You'll be able to see if this patient is a risk of becoming acutely a deterioration patient, someone that needs urgent intervention, or whether actually they've got acute pain but they're sitting there quite happily having a cup of tea and having a chat with the nurses or the healthcare staff. So brilliant. That's exactly the first thing that you want to establish. And then you're right, you take your history. If they're sat there at the end of the bed, smiling, looking quite comfortable, by all means take a full history, cover absolutely everything. Because it might be that they've got something that's causing their abdominal pain that's a bit more complex. For example, they might have DKA, they might be having an Addison's crisis, they might be having something that's not typical to a surgical pathology, and that will come out in your long history. But if they're sat there and you can see that they're pale, they're sweaty, they're writhing around in pain, or they're unconscious, sometimes you get called to these patients in resusc, you might not need to take history at all. Or you have to take a very small history, a very kind of targeted history. And a good example of that is an ankle history. Have any of you come across ankle history before?
Yeah.
Where have you come across it typically before?
Well, in ED, I've seen it, but we can sort of just do a very quick history, and especially looking into these as something unwell.
Precisely.
And a very small examination.
So from my experience, ankles mostly used in trauma settings. It's really good for patients pre-op because you're focusing on a few key questions. So allergies, medications, what their past medical history is, and that can often help you work out what's going on now, when their last meal was, and then the events leading up to presentation. Because for these patients, if they are unwell, you want to get on to investigation and treatment. That's where you're heading. But we all know that in the majority of patients, diagnosis is gathered from the history. So if you can take history, majority of the time that will give you your answer. So this is a gentleman that did come in. I saw him probably about 3 or so months ago before I rotated in my job. No allergies, classic medical history for someone that's 65, on a few medications, but I'd been feeling unwell for 3 days. He'd be getting worse, severe abdominal pain. Classically, he wasn't able to localise it, said it was absolutely everywhere, but you could tell that he was in agony. He was struggling to move, feeling feverish, short of breath, and I noticed that his urine output had started to decrease. Is there anything in that quick history that kind of alarms you or flags up as something that you'd want to make a mental note of?
Is that yeah?
Yep. Why?
Because he's got he's a nasal anticoagulant, but you can have for oxygen that can cause acute ischemia too.
Brilliant, exactly. Anything else?
Just the severity of the pain, like there's all over it, he can't even move with it if he's struggling to move.
Precisely.
Has reduced urine output means he's got signs of end organ damage from whatever things got going on.
Precisely, exactly. So these were all things when I saw him in A&E that alarmed me, as well as by the time you get there, you know this is a bit of an accurate scenario. You get a set of obs and you're told these are the obs, doctor, go in. But then taking the history, having known those obs as well, it was quite clear that there was definitely something serious going on. So examination, I'm sure you're all very comfortable with an A to E examination. The reason I put this in there is that if someone comes in an acute abdomen, it's sometimes very tempting to jump straight to the abdomen and have a feel. But really, you need to start at A, because that will still be the most dangerous part for the patient and moving through. So just because they're coming with an acute abdomen, it's really important to also make sure the other systems are also okay. It's classic in this situation that you resuscitate the patient as you go along. So if you notice that they're hypotensive and tachycardic, you put a line in and you give them some fluids or blood normally as you go along, depending on what you think the cause is. You don't always get to the very end, and you'll see that when you're in A&E most of the time with an acute patient in resus, you don't do everything and then leave it to the last minute. It tends to be a bit of a get everything going at the same time. So like investigations tend to follow ruling out the most serious of the conditions first. So what do you think, what's the most serious condition in someone that presents with acute abdomen that you need to rule out?
AAA.
Yes, that's brilliant. So yes, the AAA is the most serious one, and that needs to be ruled out in anyone that comes in with an acute abdomen or a surgical abdomen as such. Brilliant. And just keep your differential diagnoses broad as well. It's important because, as you'll see in a minute, there are lots of different things that can cause acute abdomens. And you're all familiar with the areas of the abdomen. Just keep this updated in your mind. The reason I put this in there because it's quite a nice way to be able to fall back to it. If you're there at 3 AM and you think, I can only think of two things that could be causing this, but they're not fitting. These don't match. If you do think about the structure, you might be able to help and think about things. It's not a perfect system. As we know, the nerves can cause referred pain, people can have more than one thing going on at a time. But it's quite a nice thing to be able to fall back on. So if we go through this, if you're able to tell me in each of the quadrants what would be causing, or could be causing an acute abdomen. For example, in the right hypochondrium, what could be causing pain if they're having the majority of their pain there? What would you be thinking of?
Colic.
Yep.
Cholecystitis. Sinusitis.
Yep. What things? There's loads.
Acute, well, it's not really surgical, acute hepatitis.
Yep.
Pancreatitis.
Yep. And so that's the thing, it's not surgical, but it is the cause of an acute abdomen. So that's what's important. If you're going to go with the general, what is the definition of acute abdomen, sudden acute abdominal pain, you could get that with hepatitis. But this is why it's important to know that if someone says this person has acute abdomen, you have to be careful that they might be talking about the surgical abdomen, which they might not have in an acute hepatitis. What else could be causing pain there? So you can even get things in the thorax that cause pain in the hypochondria. Really, like quite commonly we see people with pneumonias, quite severe pneumonias coming in with pain either side, and likewise sometimes even pleural effusions or pleuritic pain. People get it referred into the abdomen as well. But then the majority of your signs and symptoms are actually, your findings, you realise that it's actually coming from the chest. Okay. So these are just a few common ones that you see. You'll probably see at least one of these if you're on any acute take for a prolonged period of time. You'll see people coming in with all of these. So we're going to go through each of the regions just as a refresher really for each of you. So epigastric region, what could you expect to find?
Pancreatitis.
Yep.
Reflux, some called
Yep.
gastritis.
Peptic ulcer.
Peptic ulcer, a really good one, a really common cause of severe epigastric pain. MI, brilliant. Fantastic. There are also some other things, some things to think about that you can get as well, some things like ball halves, esophageal perforation, but then you've got the most common ones. Left hypochondria?
damage to the spleen,
So what,
splenic rupture, or
yeah, precisely. So we do see people come in with splenic rupture, or what else can happen to the spleen? In someone with AF, yes, then you can get a splenic infarction, which can be really, really painful. We do see that sometimes. You've got your pancreatitis there as well. It's not having any of these in the upper abdomen, you know, it can go across. We do see people with, sometimes with cholecystitis, it comes on the right, sometimes pancreatitis, it comes the other side as well. You know, the body isn't the same for everyone, and people do pick up pain. It's just to keep a good idea of what could be going on. So very similar things. Right lumbar and left lumbar, or flank regions, however you want to call it.
Common practice.
Well, that's really common. You'll see it being come in absolute agony all the time. Stones, yeah, really, really common. I've been thrown in the psoriasis there. You don't see them commonly, but you do get people with them. Umbilical region, there you go, I've given you some. Give me some reasons of umbilical regions important.
appendicitis.
Yeah, early or late?
Early.
Pancreatitis.
Relate. What else? Obstruction, yeah. Perforation, brilliant. So with a few of those, for example, your appendicitis, why does it go to the umbilical region? Why do they get pain there?
The first has to do touching the nerves of the peritoneum, isn't it? And it migrates.
It's migratory pain. So that's why they feel it classically in the right iliac problem because of the irritation of the parietal peritoneum. So normally it starts in, do you remember your embryology of your gut back in the day when you sat in those lectures? So the appendix sits within the portion of the bowel that's supplied by the SMA. Okay. That part from the nerve supply goes to the umbilical region, so that's the visceral peritoneum being irritated. Okay. Then when it gets late, when the appendicitis develops and it's bulging and it's nasty and pus is coming out of it, it physically touches the parietal peritoneum, and that's when you get people saying it's there. That's the place. So it's slightly different. It's the change between the visceral peritoneum and the parietal peritoneum being affected. And that's why quite commonly someone mentioned ischemic bowel, someone mentioned obstruction. Commonly, those appear, the pain is more midline for that very reason. Because the bowel doesn't feel pain in the same way. It feels pain for infarction and distension. And if you think about it, that will go back to the visceral pathway of peritoneum and that's why it's irritated where it is. Okay. Brilliant. So I don't think there's much dissection. That's another one. Keep it in your mind. Because if you don't think about it, it's one of those things. But again, it's not something you see every day. In children, so most of the time we think about adults, but here we do have children come through as well. We do have paediatric inpatients. And their conditions are slightly different. So, for example, we see a lot of people with query appendicitis, actually it's metameteric adenitis after they've had a cough or a cold. Another thing to think about, if you have a normal appendicitis, especially operating, and you see that the appendixes are normal, you have to think about menopause diverticulum as well. So these are quite common, but it's thinking about the age group of who you've got in front of you. Do any of you want to work with paediatrics? So you might not see so many of these, but it's something definitely to think about because it can affect adults as well. So left lumbar is pretty similar to the right side. Right iliac fossa, what could we have here?
Variances.
Yep.
Origin.
Yep.
Ectopic.
Ectopic, yeah.
Appendicitis.
Mm-hmm. Anything else? With the ectopic, not only having the ectopic, but what's the worry with someone with an ectopic pregnancy? Yeah, that it ruptures. Yeah. We've got a few things there. That's pretty similar. In the IBD, you've got your terminal ileum in that area as well. Okay, you can have UC pain there, but UC is along the large bowel. So you do classically get it more on the left-hand side. But obviously, it depends on the person. You can get different things. And strangulated hernias. Groins are really common place for people to get inguinal hernias, femoral hernias. These can radiate pain into the iliac area. Hypogastrium or suprapubic region, depending on what you want to call it. You get that.
Cystitis.
Yeah, come on.
Extension.
Yeah. When you go to urology ward, most people come in with an acute abdomen due to retention. It's really painful. And patients will want to marry you after you put a catheter in them. Solves it, pretty much like this. What else?
Can you get diverticulitis?
Yeah.
Also, I guess on left, but
Of course. What about in the man? What should you worry about?
Testicular torsion.
Yeah.
Is that more hypogastric? Is it not sort of generalised?
It can be generalised, but in my experience and in the literature, it does normally say that it's suprapubic. But it can be generalised. You know, this isn't a hard and fast rule. You can have people with diverticulitis that have no pain on the left, it's all on the right. You can have people with, like I say, pancreatitis, and it's all on the right where you'd expect it to be more in line on the left. But it's to keep it more diagnosed, a big reason why you can have it. And then left sided, we touched on most of them, I think, that go on the left. What would you think about?
Similar gynecological
Yeah.
prognoses, and then, as I said, the diverticulitis.
Yeah, diverticulitis. You've got your sigmoid there as well. Okay. It's quite common presentation. Most of you probably seen a sigmoid volvulus at some point, I imagine. Okay. So this is quite a common thing. Just keep this in your mind. Try and keep it updated because it's easy for them to slip. But it gives you quite a broad list of different pathologies that can cause an acute abdomen. So you've gone to examine our gentleman in A&E. So he's got peritonitic, rigid abdomen. He's tender in the left, umbilical and suprapubic regions. He's guarding in the left iliac sort of rebound tenderness. He's got percussion tenderness also. That sounds negative, and DRO is empty. What do you think of this patient?
Could he perforated bowel secondary to obstruction?
Yeah. So but with these findings, these are quite abnormal findings, aren't they? These are findings that you would act on. It's not a normal exam. So have you all felt a rigid abdomen? Are you all confident what a rigid abdomen feels like? Because most of the time, if you draw the abdomen and you say, SNT, soft non-tender. Lots of people, when you see them, their abdomen is soft, and it is non-tender. But if you see someone with an acute abdomen, you expect it to be tender, they've got pain. But if it's not soft, if it's rigid, if it's hard, that means that the peritoneum is irritated. And this person is guarding their muscles, and they've changed the way their abdomen is feeling because there's severe pathology going on inside. These patients, classically, you'll ask them to examine them because you'll probably want to listen to their chest as well. You ask them to move, and they don't want to move for you. They're lying flat in the bed. And if you ask them, how was the journey on the way here, and they'll say, I felt every single bump in the road. They'll be quite honest about it. You don't want to really move them around too much because they are in agony. Okay. Guarding. Do you all know what guarding and rebound tenderness mean? What's guarding?
Because when you tense your abdominal muscles, causing either microjuice pain or peritonitis.
Yeah.
So when you go to press on it, the tendon is really tense and not soft.
Yes, exactly. So that is what guarding is. And what's rebound tenderness?
Is that when you press down, so when you remove the finger, it's more painful? Removing the finger, yeah.
It's more painful on rebound. Okay. Do you know why that is?
Is it going to do with sort of irritation of the layers when it comes into contact with the parietal layer?
Yeah, so it's bouncing back, and that movement is extremely painful because it's irritated and inflamed. Okay. Percussion tenderness is actually a really good sign as well to try and do. A lot of people jump straight into palpation of the abdomen, but do try and percuss and fully examine the abdomen, listen for bowel sounds. A lot of people, if they've perforated or they've got a severe cause of an acute abdomen, if they do have an inclusion, they normally have paralytic eyelids. They won't have any bowel sounds if it's severe. In obstruction, obviously, you can get tinkling bowel sounds or increased bowel sounds, but perforation, you tend to get no bowel sounds. And here the classic, remember to do your PR exam. It is really important, and the classic side, if you don't put your finger in it, you'll put your foot in it. So you can get really useful findings from it. It can change your management plan altogether depending on what you get. So, investigations, things to do. So you're going to take bloods. There's quite normally a large batch of bloods for someone that's coming in with an acute abdomen. Your full blood count, you're using these, your coagulation screen. Okay, CLP, LFTs, anyone with an acute abdominal pain, get them an analyse as well. You might not think it's pancreatitis, but we can all get caught out. Some come in with raging pancreatitis. It's not common in the way it presents. For surgical patients especially, it's important to get a group and save, plus or minus a cross match, especially if you think the patient might be going to theatre. CBG is really useful. You tend to get it in your normal batch. In A&E especially, you get handed many VBGs throughout the day to check if they're okay or not. But they provide a wealth of information, so it's worth looking at. And always think about doing cultures as well, especially if you think there's an infected cause. Okay. ABGs can be very useful in the sick patient. And here I've put chest x-ray. We do frequently get them. The patient might not be well enough to get on, but if you can, try and get it erect. Why is that, do you think? Why are you looking for erect chest x-ray? Yeah, precisely. Okay. I put abdo x-ray in here. Some people like doing them, some people don't. Again, depending on where you work, some trusts like you to do them in someone with an acute abdomen, others will just say go straight for a CT scan. So go for where you work and what your seniors think as well, but they can be really useful and help you with, if someone has an obstruction, they can be really useful. If someone's got perforation, however, we tend to just go for a CT scan, or you take them to theatre, depending on if they're too unstable. Okay. In A&E, we do fast scans. It won't be done by you, but normally one of the A&E regs is trained to do it. If they're worried about that AAA, if someone comes in, it's a good way to think about if there's any free fluid in the abdomen. And these are other things that you can do for people with an acute abdomen that's not maybe so unwell at the time. So those people coming in with biliary colic, we're thinking renal colic, you can sometimes do ultrasound scans before getting CT scans. I've written just that any female is get a pregnancy test. We all get caught out. It's important. Okay. Management of the acute abdomen, because you've seen there's so many different possibilities of things that can cause an acute abdomen. The management is really dependent on what the cause of it is. But a few things to think about in any of the sick patients is resuscitate them, start from the basics. If they need oxygen, put oxygen on. A lot of people that come in with a surgical pathology, however, they'll need IV fluids. A lot of them will need antibiotics. It's a good idea to put a catheter in and monitor their urine output as well. We often want patients nearby mouth. So it's normally for that, if we want to decompress the stomach, it's worth putting in an NG tube, especially if they're coming in obstruction as well. Make sure they have adequate analgesic and antiemetics. I'm sure you're all comfortable with sepsis 6. Does anyone want to just reel off what the 6 points are?
Well, there are 3 in, 3 out. So
Yeah.
anything you want is IV fluids, you want antibiotics, you want oxygen.
Yeah.
And then out, you want lactates, you want urine outlets, and you want cultures.
Fantastic. Brilliant. I think it's important when you go and say that to someone with your urine output, specify in these patients, because they're going to need a lot of monitoring. Say you want a catheter with a urometer and you want hourly urine outputs. Do you know how much, what you're looking for with their urine, the amount of urine that you're wanting out?
So 0.5 ml per kilogram per day should be the urine output per hour, yeah.
Yeah, per hour, so 0.5 mils per kg per hour. Okay, so that's the absolute minimum. Normally you're wanting a bit more than that. So normally I calculate that for the nurses, so I work out what it should be. And I say if it drops below that, let me know straight away, or let one of the surgical team know straight away. Okay, because it means that you're falling behind. With any patient that comes in with an acute abdomen, I think it's really important to escalate these patients to your seniors early, whether that's in medicine, A&E or surgery, because they have the potential for becoming really, really unwell, especially if they're presenting like our gentleman in A&E did with parasitism like this. You want the senior to know about them straight away, because what you're thinking about is whether they need to be taken to theatre. And we're lucky within our hospital as well, we have critical care outreach, and they're a really useful resource with someone that's acutely unwell to get help from managing these patients as well. And are you all familiar with the emergency laparoscopy pathway? It's worth finding it in this hospital. Every hospital has a different pathway for someone that comes in and needs an acute emergency laparoscopy, but it's worth being familiar with it. It's normally a lot of documentation, but it's worth getting familiar, because then if someone does come in, it covers a lot of points of things that you need to be doing, so you know that you're not missing anything for those patients. Okay. So I'm going to go through a few of the most serious causes of an acute abdomen for you. Okay. So we mentioned it earlier, the most life-threatening causes of an acute abdomen is the ruptured AAA. But there are other things that can cause bleeding. We mentioned the ruptured ectopic pregnancy, peptic ulcer, and trauma. There's going to be more, but these are ones that you will commonly see in a district general hospital. These patients typically are tachycardic, hypotensive, they're cool, clammy, shut down around the peripheries, and they're basically in hypovolemic shock, hemorrhagic shock. Okay. So another thing that you can think about managing these patients is a major transfusion, getting them blood, all these things, making sure they don't have any coagulopathies. The most common cause, what's the most common cause of an acute abdomen? No. What do you see all the time coming through the A&E?
UTI.
So if you think about the acute abdomen being a surgical abdomen in this respect.
Exactly.
So it's normally due to perforation of the viscus, whether that be peptic ulcer or diabetic disease. The most common, and you see it a lot, because there's a lot of pathologies that can cause a perforation. There's not just a couple, there's an absolute range. So perforated viscus, so it's commonly due to perforation of the abdominal viscus, peptic ulceration, obstruction, diverticular and inflammatory bowel disease. These are conditions that you will be very familiar with, so that can lead to perforation. Okay. Classically, these patients again will be tachycardic and hypotensive. These are the patients like our gentleman, they will have a rigid abdomen. They'll have involuntary guarding and reduced absent bowel sound. We went through all of that earlier. What does this chest X-ray show? The pneumoperitoneum. So it's a really good thing just to get. They're quite easy to get, very quick. Most patients tolerate it, and you can see air. In children, you can't always get, or in some people, you can't always get erect chest X-rays. Sometimes in those, you can get lateral X-rays, and that will also show pneumoperitoneum. Ischemic bowel. So again, we do see patients with ischemic bowel coming. In these patients, the pain tends to be what appears to be out of proportion to your clinical findings. And in those patients, you need to consider an ischemic bowel to prove an otherwise. Things that can help is getting your VBG, your ABG, seeing what your lactate's doing, what your pH is doing. But ultimately, a lot of the time in these patients, they end up getting CT scans, because you need to make sure that their bowel wall isn't ischemic. Okay. There are a few patients that come in and you just think, I'm not sure, it's not adding up, and they might have an acute ischemia of their bowel. Have any of you seen someone with an ischemic bowel? You have. Did they present in a similar fashion?
Yeah.
It's quite classic. I think we all think with the word ischemia that it's going to be like an MI. When you get ischemia with an MI, people have the crushing central chest pain. It doesn't always happen the same way in the abdomen. So peritonism, common example of this is appendicitis. But lots of different things can cause peritonism without being kind of a surgical abdomen as such. And we mentioned why the different pathways of the visceral versus the parietal peritoneum and why that happens with appendicitis. Another thing we mentioned is colic. Part of the history that's important to mention is the fact that it tends to be intermittent in colic. As you're getting the spasms along the tubular structure that the stone is normally stuck in. And so they get crescendo of pain, and it will be absolutely unbearable, and then it will settle down. Okay, so that's common in quite a lot of patients. It's not, again, not a hard and fast rule. For these patients, it can be really useful giving them a muscle relaxant type medicine such as buscopan that can really help, an antispasmodic. And classically, unlike a peritonitic chap that's lying in the bed, these patients are wriggling up and down, sitting up, standing up. They can't get comfortable in any position at all. So this is just a slide just to be aware. So certain groups of patients that present slightly differently to, let's say, your 50-year-old adult man. Okay. Elderly patients, really worth being aware of. With their physiology, they might not present in a classic way at all. And quite commonly, even if they have severe pathology going on, they might not experience pain. They might become quite unwell before you actually start picking up that they've got something really serious going on. And children also, they can appear right as rain, right until the very last minute, because they've got so much reserve, and then they, if you like, fall off the cliff, and things start going really, really wrong. So keep a really broad idea of what it could be and get your seniors involved early. I've mentioned here immunocompromised patients, patients receiving peritoneal dialysis. Because you've got a port, you've got an entry into the abdomen with those patients, it can be therefore that they're more likely to get peritonitis. Okay, the immunocompromised as well, because they're more likely to get infection. Ascites and SPP, I'm sure you've all seen people with SPP. Again, peritonitis tends to be medical management, and they respond really, really well. And pregnant women. I'd say if someone comes in that's pregnant with an acute abdomen, these are definitely ones I recommend getting your senior involved early. Because it might be due to the pregnancy itself that they're having the acute abdomen, but also if they're heavily pregnant, it can be really difficult to even examine these patients and get accurate clinical findings. Then progressing through management, you want someone early, because if you're needing scans for these patients, and the idea of taking them to theatre, there could be a lot of planning that needs to be involved, so they're worth knowing about early. So I've just got a few x-rays. If you are going to get that abdominal x-ray, it's worth having the idea of a few common things that you might be seeing. And you'll see that through the light, the sun's just started shining today. What can you see there? Can you see it first of all? It's not great.
It looks like a small now. I think I can see from how the prognosis.
Yep.
It's just a little smaller than what's it supposed to be.
Yes. So what would this be classically?
So it's more large.
Brilliant. Yeah. Are you happy with that? So it tends to be the centre of the abdomen. We mentioned the valvular convolutus. That's the fact that the line crosses the whole diameter of the bowel, unlike house drum, which are only partial. Okay. And you're talking about the 3, 6, 9 rule, I think. So you can measure it essentially with our PAC system. Small bowel should be greater than 3 centimetres, large bowel greater than 6, and cecum greater than 9. What about this one?
Is that a large bowel obstruction?
Yeah. So this is classic for large bowel. So you can see large throughout, you can see air throughout the large bowel, and then it kind of stops about the rectum there. You have some air in the rectum lower down as well, so some areas getting through, but that's a good way of working out where you think the obstruction is. You basically find the transition point. So it will all be dilated up, and you'll see it, and that's what they're looking for when you see your senior scroll through CT scans. And then they're looking for a point that pinches, and then the bowel is of normal calibre afterwards. So common things that cause that in the large bowel, things like malignancy, and in small bowel, things like adhesions. And that's what we're looking for, that change in calibre. Because it basically tells you where you need to look for when you do your operation, where the pathology is. Brilliant. Well done. Why are you thinking it's a sigma plus?
Coffee bean shape.
Yeah, really. I I think this was quite a good image of the coffee check, and you'll see it. You can all see it, so it's quite classic. These patients, they come in with obstruction, but it tends to be, they got obstructed almost like that, and they come in highly distended. It's quite quick. When we see these patients, people can get recurrent sigmoid volvulus, and you see the same patients again and again, as the bowel just flips on that mesentery. For these patients, sometimes a rigid sig or a flexible sigmoidoscopy is what they need to decompress and kind of reverse that twist in the mesentery and reduce the pressure. Sometimes you do see this in people with pseudo-obstruction as well. You might get people commonly in geriatrics, people with lots of comorbidities that just have basically a very atonic colon erectum, and they end up getting constipated and have these pseudo-obstructions, and they see them a lot. And they do need, normally it's the same treatment, they end up getting decompressed, but it's not actually a twist in the mesentery, if you like, or a volvulus, but they present quite similarly. What about this one? Not sure. What does it look like? It just starts from the kind of basics. What can you see? Does this bowel in the middle look normal to you? No, so it looks abnormal. Why does it look abnormal?
It's very distended, but still aware.
Yes, so it's very distended. So you think there's an obstruction or a volvulus or something like that going on. Can I convince you that down here, I don't know how well you can see it, but it looks like there's a small bowel down there. You can see the valvular kind of ventilated. Are you able to see that? The light's not really, I don't know if it's worth closing the blinds. Kind of, I'm going to have a look at it on the screen here. You can see that there's small bowel down there. So what's happened is in this patient's got a cecal volvula. So the cecum has twisted on its own. They present quite similarly to sigmoid volvula, because they get a sudden twist in the mesentery, distension, not able to open the bowels. It's quite similar, but the treatment is going to be very different for these patients. So normally these patients get a CT scan, and it's sometimes even during operation that they find that it's not being corrected. The CT scans tend to go ahead with these. They're a bit rarer than the sigmoid volvulus, but you do still see them. It's worth remembering. You can get volvulus ambulatories as well. See people sometimes come with gastric volvulus that comes a bit higher. I think that covers kind of the basics of an acute abdomen, things that you'll be able to take forward and use. Any questions about any of that? Thanks, guys.